So hello everyone, this is Dr. Shubham. So in this particular session, we are going to start with the autonomic nervous system. In the previous two classes, we had some basic concepts about the general pharmacology, but especially in this session, we are going to start with the main pharmacology, or you can say that we're going to gradually, driving ourselves into the journey of pharmacology, right? So in the today's session, we'll talk about here and there some drugs. So basically we'll be trying to discuss about some of the drugs who are coming in the category of cholinergic agonist. So basically we are going to talk about the cholinergic system. So firstly we'll build some concepts upon the cholinergic system, how the neurotransmitter works, what are the neurotransmitters we are going to talk about in this, and how the action potential works as far as neurons are concerned, and all of those stuffs we'll be discussing about, which I'm sure you must have studied about them in the physiology as well. And then we'll try to gradually build upon the drugs and all that, how the cholinergic system works, and what are the several drugs which we can talk about in the cholinergic system. So in this particular session I will be restricting myself to the cholinergic agonist only. That is basically they are those drugs which will be stimulating the cholinergic receptors, and in the next session probably we'll be talking about the drugs which will be blocking the cholinergic receptors, right? So those drugs will be called as the anticholinergics, or you can say them as cholinergic antagonist. So let's start our today's session with the cholinergic agonist basically. So these are some of the MCQs which we will be discussing them after the discussion, as you already know. So let's start with the cholinergic agonist. But before starting that, we should have some basics in our hand so that we can just talk about and build some more concepts upon this topic. So firstly I want to discuss about the autonomic nervous system, right? ANS, that is basically your autonomic nervous system. And if you talk about this autonomic nervous system, then we are having two branches in this system, right? As you know that we are having two branches in this system. And what are these two branches? Everybody knows that one is the sympathetic nervous system, right? Sympathetic nervous system, and another one is the parasympathetic nervous system, right? Parasympathetic nervous system, very easy, right? So we are actually studying this system from many years, that sympathetic and parasympathetic, from our second third years. So sympathetic nervous system, basically we are talking about that fight and flight response, and parasympathetic is mostly about the rest and digest, which we are studying this, right? So fight and flight response we are seeing in the sympathetic nervous system, right? This from your basics. And rest and digest, right? Rest and digest response is seen in the parasympathetic nervous system. Let's talk about more about this system, like what is the origination as far as this system is concerned and all. So here is the diagram you can see over here on your screen right now. This is nothing but a brain and the spinal cord I want to depict over here. So basically if you talk about the parasympathetic nervous system, right? If I'm talking about the parasympathetic nervous system, it is actually originating from the craniosacral region. What is the craniosacral region? This particular part is obviously the brain, which is coming in the cranium region, so I'm just calling it as C. And the the lowest part of the spinal cord, okay, particularly this much region, we'll be calling that as sacral region, so I'm just writing it as S, right? So craniosacral portion or craniosacral part basically. Now if you talk about the parasympathetic nervous system, basically it is originating from two things in our nervous system, right? From the brain it's cranial part, from the spinal cord it's the lowest portion of the spinal cord, that is the sacral region. So combinedly we are saying that the parasympathetic nervous system fibers, they are originating from the craniosacral region as far as our nervous system is concerned, right? So the fibers of it will be coming up from this region. As far as parasympathetic system is concerned, it is originating from this region, right? This region. And what is this region? This is the thoracolumbar region, right? We know that in this region we are having the thoracic region and we are having the lumbar region. If we talk about vertebrae also, like thoracic vertebrae, lumbar vertebrae, so like that thoracic region and the lumbar region. So that's why we can easily say that craniosacral region as far as parasympathetic nervous system is concerned, it is considered with that. And if you talk about the thoracolumbar region, it is concerned with the basically sympathetic nervous system, right? So let's talk about more further like fibers, right? Once you have this basic knowledge, let's talk about more about this one. If you talk about the cranial cranial region, which cranial nerves are actually included over here. So the cranial nerves are cranial nerve 3, cranial nerve 7, cranial nerve 9 and cranial nerve 10. Okay, these are the cranial nerves which are included, from where these fibers are actually originating from. So let's say these fibers are originating from that place, right? These are the fibers which are originating from that place. Okay, and here is the ganglion, right? Here is the ganglion. Let's say this is the ganglion, right? So before the ganglion, these fibers are called as the preganglionic fibers. Very easy, these are called as the preganglionic fibers, and obviously after the ganglion they will be called as the postganglionic fibers. So there is no surprise in that, right? So obviously after that we will be having some fibers again, and they will be ending up somewhere in some particular organ, let's say, right? So here, right, they are ending up in some organ, let's say they are ending in the eyes, in the pupil, right? So this is the craniosacral region. I'm talking about the parasympathetic fibers, right? So here if you talk about in the cranial nerve, we have talked about this cranial nerve nuclei 3, 7, 9, 10, right, from the cranial part. And if you talk about the sacral part, here we are talking about the S2 to S4 region. Okay, S2 to S4 region, right? From here the fibers are originating. And if you talk about, okay, so same fibers will be originating from there. I'm just not showing it again, right? In the thoracolumbar part, I am considered with the sympathetic nervous system, right? So I'm just showing it like this. For example, here I'm talking about parasympathetic nervous system. So it is concerned with these two, cranial and the sacral region. Okay, and if I'm talking about the sympathetic nervous system, right, SNS I am writing over here, that is concerned with this particular region, right? That is the thoracolumbar region, right? Now let's say the ganglions are actually appearing out from this region as well. And this is the ganglion over here, right? This is the ganglion over here. So these fibers will be called as, before the ganglion they will be called as preganglionic fibers, and after the ganglion obviously they will be called as the postganglionic fibers, right? Here also they are ending in the particular organ, right? And here let's say this is the blood vessel, right? Let's say this is the blood vessel over here. Okay, they are ending over there. Now we should know about the neurotransmitter over here as well, right? What are the neurotransmitter? If you talk about the preganglionic fibers, like where which they are ending in the ganglion only, here the neurotransmitter will be the same in both the system, in parasympathetic and sympathetic. Here the neurotransmitter will be the same, that is the acetylcholine. I am just writing ACH. Okay, that's how we denote acetylcholine. And if you talk about the postganglionic fibers, okay, in the parasympathetic nervous system it will be the same, acetylcholine only. But if you talk about the sympathetic nervous system, it will be different this time, and this will be the norepinephrine this time over here, right? So that is the basic difference which you need to know. Second thing is, as you can see over here, you can easily appreciate that preganglionic fibers are longer in the parasympathetic nervous system, but they are shorter in the sympathetic nervous system. At the same time, you can say postganglionic fibers, these are the postganglionic fibers, right? These are the postganglionic fibers because they are present after the ganglion. Very easy, right? Postganglionic fibers. So you can say postganglionic fibers are shorter in the parasympathetic nervous system, but they are longer in the sympathetic nervous system, right? This much you should know. As far as receptors are concerned, if you talk about the parasympathetic nervous system, we will be concerned about the receptors such as muscarinic receptor and the nicotinic receptor. These will be the receptors as far as our parasympathetic nervous system is concerned. And if you talk about the receptors of the sympathetic nervous system, they will be alpha and beta, right? We'll be talking about them in the upcoming sessions when we will be talking about the adrenergic system. One more thing, parasympathetic nervous system is concerned with the cholinergic nervous system or cholinergic system. Okay, so parasympathetic nervous system is basically concerned with what? Is basically concerned with the cholinergic system, right? So basically we'll be focusing on the cholinergic system today. So cholinergic system, right? So in that manner we'll be focusing on the, okay, I just wrote it wrongly over here. Actually it should be written over here, right? So anyways, right, okay, let's write it over here. So we will be focusing mainly on the cholinergic system in the today's session, right? So we'll be talking about basically parasympathetic nervous system, right? So we'll be focusing today on this particular system, that is the parasympathetic nervous system, right? On the other hand, if you talk about the sympathetic nervous system, okay, I'll be just rubbing it over here so that we can understand. So if you talk about this system over here, then sympathetic nervous system, that means we are talking about the adrenergic system, right? That we will be talking about in the upcoming sessions when we will be done with the cholinergic system, right? So this much we should know, that cholinergic system and the adrenergic system, right? I hope I am clear till now. So basically in today's session we'll be talking about the cholinergic system. So in a nutshell, we can say that we'll be focusing on the parasympathetic nervous system for now, right? Rest and digest response. Once we are clear with this particular thing, now we need to talk about the action potential theory, right? You must have heard about the action potential from the second year itself in the physiology. Okay, we have studied about the action potential in the neurons, in the muscles, in the cardiac muscles, skeletal muscles, and all of those things. So let's talk about in the action potential over here, just to make an understanding, like proper view about this particular system, right? So action potential, basically we are going to talk about that in the nervous system, obviously, because we are talking about basically the neurons over here, right? So action potential, how it is working in our nervous system and all, so that we can just build up our concept and we can move further. So let's say here is one one neuron, right? Let's say here is one neuron, okay, and let's say this is the another neuron present over here, right? So we are saying that this one is the presynaptic, this one is the presynaptic neuron, and next to it is will be the postsynaptic neuron, right? So next to that will be the postsynaptic neuron, right? Inside the presynaptic neuron, basically we are having a vesicle. Okay, I'm just drawing it with a different color so that you can easily appreciate. So there is a vesicle inside it, and inside the vesicles we are having the neurotransmitter, right? Now, because as I said that we will be focusing today on the parasympathetic nervous system, that is the cholinergic system. Which neurotransmitter I told you? Preganglionic also, postganglionic also. We have talked about the acetylcholine neurotransmitter. So here inside that we are having what? We are having the acetylcholine, right? Actually what happens is that whenever the action potential is coming, right, from one neuron to the other, from one neuron to the other, so whenever the action potential is coming down, right, there is a special voltage gated calcium channels are present over there, right? These are the voltage gated calcium channels. So as the action potential arrives at this particular neuron, what will happen? There is an influx of calcium ions. Due to that, there is an influx of which ions, guys? There is an influx of calcium ions, as they are voltage gated calcium channel. So there will be the heavy influx of the calcium ions. What they will do is, this vesicle which you are seeing over here, let me just mark it over here. This is called as a vesicle. Inside the vesicle is actually acting as a storage form for the acetylcholine, which is a neurotransmitter over here. So what this calcium ion will do over here is that it will bring this vesicle close to this presynaptic neuron. I mean, it will bring this vesicle close to this particular presynaptic neuron. Okay, so eventually what's going to happen is that there will be the fusion, right, of this particular vesicle with this presynaptic vesicle, right? So it will be looking like this, something like that, isn't it? So who is doing that? Because of this calcium ions influx, it is happening. So as a result, what will happen, guys? As a result, this acetylcholine will be having chance to go outside and come in this particular synaptic gap, right? This is the synaptic gap, basically, right? So what is this? This is the acetylcholine. This is the acetylcholine simple, right? So this space is called as the synaptic gap. This space is called as the synaptic gap. This is space I'm talking about is called as synaptic gap. So I'm just repeating. Action potential arrives at this particular neuron. Due to that, it will be just stimulating this voltage gated calcium channel. They will open up. As a result, calcium ions influx will be happening. As a result, what will happen? Fusion of the vesicle with the presynaptic neuron, that will happen, and as a result exocytosis of acetylcholine will happen. right? Exocytosis means like the acetylcholine, which is a neurotransmitter over here, that will be coming out from its presynaptic vesicle, right? Okay, once it will be coming in the synaptic gap, here we are having a receptor, right? Here we are having the receptors. Let's say these are the receptors present over there, right? Very easy. These are the receptors. Which receptor I'm talking about? I'm talking about the cholinergic receptor, right? Okay, further I will be talking about, we are having Muscarinic receptor and the nicotinic receptor. I'm talking about right now neurons. I'm just talking about the, let's say this is the neuronal receptor, okay, that let's say this is the nicotinic receptor over here, right? So these are the receptors. So obviously this acetylcholine will be having the chance to bind to these receptors, right? And it will further show the action. How it will show the action? Over here we are having a one more channel, and this time it is the sodium channel. Now what will happen? Influx of sodium will happen. Influx of sodium will happen, right? Here is the sodium ions. Influx of sodium happens, and due to that further action potential will be seen. Due to that further action potential will be seen, right? So very easy to understand. Okay, once we have understood about this particular action potential, that how it is happening, right? Let me just describe it once again, right, in some different manner. Let's say again, like you are having a basic idea now, right? Again guys, nothing but we are having this particular, presynaptic neuron, and we are having this again postsynaptic neuron, right? Same things we are just repeating once again. We had the presynaptic vesicle, if you remember over here. Yes, we had the presynaptic vesicle. Okay, now I'm just going in bit detail over here. Here is what, guys, can you remember, can you just name me this particular structure over here which I'm drawing right now, right? I'm sure you might have heard about this structure, you might have seen this structure. That is the, yes, I can hear that, that is a mitochondria, right? That is your mitochondria. And from the mitochondria, what will be happening is that you will be having the acetyl coenzyme A, right? From this mitochondria, I'm just getting what? I'm just getting the acetyl coenzyme A, acetyl coenzyme A, right? Once you're getting this acetyl coenzyme A, what will happen? Here is what, just remember this. Yeah, here is the, yes, blood vessel. From the blood vessel, right? This is the blood vessel. I'm just writing BV. So from this blood vessel, actually what you can see is that our choline is coming. What is coming? Choline. So here it is introducing what? It is introducing the choline, right? Yes, this is introducing the choline. And then what will happen? This acetyl coenzyme A and the choline, okay, they will merge. They will merge and they will make a product over here. Which product I'm talking about? They will make a product that is called as the acetylcholine. That is called as what? Acetylcholine. That's how you are getting the acetylcholine. But here we are having an enzyme over here, right? Here we are talking about an enzyme. So this is making this acetylcholine. So what is this enzyme which I'm talking about over here? This enzyme name is called as the choline acetyltransferase, right? Choline acetyltransferase. Okay, once this acetylcholine is formed, now what will happen? Everybody knows that it will be entering inside this presynaptic vesicle, as we have discussed this, and then it will be storing inside this vesicle. It will be storing inside this particular vesicle. Simple. Till now everything is clear, I guess, right? Now what will happen? This acetylcholine will be actually moving out, okay, and you know this, how it is moving out, right? With the help of this calcium ions influx, it will be moving out, and now it is present in the synaptic gap. Now it is present in the synaptic gap, right? I'm not just repeating that thing because we have discussed that already, right? All that calcium channel will open up and calcium influx will happen, and all of those things will be happening over here. That you know already, right? Here it was a voltage gated calcium channel, and calcium ions were actually coming inside, and the fusion happens basically, and then finally it came into this particular synaptic gap, right? And here again, with no surprise, that we are having a receptor present over here, and they will bind to that and they will cause the action. How they are causing the action? Again, here we had the sodium channel present over there. Due to that, so sodium influx will be happening, and that's how the action potential will be further moving on to this particular neuron, and then this cycle repeats and repeats and repeats and keep on repeating, right? So once we are having a good idea about this, let's talk further. Here we are having a very important enzyme present over here. That important enzyme is presenting like a seizure, and these particular seizures, okay, because they are cleaving down the acetylcholine, right? So as they are cleaving down the acetylcholine, so let me just talk about that. So here we are having an enzyme over here that is called as the acetylcholine esterase, right? So here we are having an enzyme that is called as the acetylcholine esterase. Now what this enzyme will basically do, it will just cleave down the acetylcholine. As you know that in the synaptic gap we are having acetylcholine over here. Acetylcholine will be dividing itself into two parts again, which was, so here is the acetylcholine, let's say here was the acetylcholine, so it will be dividing into two parts. That is the one is the acetyl coenzyme A, and second one is the choline, right? One is the acetyl coenzyme A and the second one will be the choline over here. And what will happen, choline will be further reuptake back and the acetyl coenzyme also will be further reuptake back. But over here what we can see is that what is this particular seizure which I am talking about, what is the particular enzyme, that is called as the acetylcholine esterase, right? That is very important, acetylcholine esterase, because further I will be talking about some drugs which we will see that they will be acting upon this enzyme and will be further causing an action. We'll talk about them, we'll read about those drugs further, right? Okay, once we know that there is a enzyme, acetylcholine esterase enzyme is there and all of those things, right? Choline will be actually reuptake back. Okay, so this choline we can see that this will be actually going back, right? Yes, this will be going back where, yes, here only, yes, this will be coming back over here, right? So till now everything is clear, there is no confusion in this particular data. Now we can actually move further and let's talk about some drugs over here, right? So we are going to introduce some drugs as far as this system is concerned. Just writing with that with a blue color, fine. So first drug which I'm going to talk about, that is the hemicolinum, right? That is a hemicolinum, and actually it is inhibiting the uptake of choline, right? So there is a drug, first drug which I'm going to introduce over here, that is the hemicolinum, right? Hemicolinum, and what it is doing basically is that it is basically inhibiting this uptake over here, right? That is of hemicolinum, right? As you can see, hemicolinum, with as the name suggests. Then we are having a second drug over here, that is the visamicol. What visamicol is doing, this acetylcholine was going into this presynaptic vesicle. So the visamicol, what it is doing basically is that it is stopping or it is inhibiting this entry over here, right? It is inhibiting this entry over here, so acetylcholine will not be able to go into the presynaptic vesicle. Third drug which I'm going to introduce over here, these are the aminoglycosides. What they are doing now, aminoglycosides simply, as you can see, the voltage gated calcium channels were there, right? They are actually inhibiting these channels, right? They are actually inhibiting these channels so that calcium influx will not be able to happen. And you know that if the calcium influx will not happen, the exocytosis of the acetylcholine will not be able to happen further, right? So that is the use of this aminoglycoside. That's how the drug is working over there. And the fourth drug we are also having, that is working on the exocytosis directly, that is working on this exocytosis directly. And this drug basically we are having, one is the beta bungarotoxin, right, which is coming from the the snake venom, basically lapid snake. And another one is the botulism toxin, right? Another one is the botulism toxin. So this is the fourth category over here, right? Fourth category over here. Do not ignore this section over here because the question has been asked in the previous section. Yes, as far as clinically you have clinical data is concerned, as far as clinical practice is concerned, we are not using them anymore. They are more useful for the experimental purpose as such, but for the theory purpose, for the exam point of view, this is really very important. Now let's move further. Once we have talked about this particular data, okay, I'm just repeating. Hemicolinum was just inhibiting the uptake of choline into this presynaptic neuron. Visamicol was inhibiting the migration of acetylcholine into the presynaptic vesicle. Third one, I talked about the aminoglycoside, which was inhibiting the voltage gated calcium channel, and the fourth one is the beta bungarotoxin or the botulism toxin as such, which was actually inhibiting the exocytosis of the calcium into the synaptic gap, right? I hope I've just made the data clear till now, right? Now let's just move further, okay, and let's talk about some more things. If you can see some of the receptors present over here, right, on the postsynaptic neuron. This could be the muscarinic receptor, and this could be the nicotinic receptor, right? It just it just depends on the location, which location you are talking about. So either it can be the M for muscarinic, either it could be the N for nicotinic receptor. Okay, we'll talk about these receptors also in a bit over here, right? So some drugs can directly stimulate these receptors, right, and they will be called as the direct cholinergic agonist. Some drugs will be there which they will be acting on the acetylcholinesterase enzyme. Okay, some drugs will be there, they will be acting on the acetylcholinesterase enzyme, and then they will be causing the accumulation of acetylcholine in the synaptic gap, and then it will be stimulating them, right? So I'm saying, let me just clarify this data further. So over here we are talking about the receptors. Okay, we are talking about the receptors. Okay, so receptors, as far as receptors are concerned, we are having two receptors, right? We are having muscarinic receptors over here. We are having muscarinic receptor, and we are having a nicotinic receptor over here. Okay, we are having a nicotinic receptor, right? So these are the cholinergic receptor which I am talking about right now. So muscarinic and the nicotinic, two receptors are there. As far as nicotinic receptors are concerned, okay, we are having further subtypes. Okay, one is present in the muscle, that is the neuromuscular, and another one is the neuronal. I'm just denoting it like that. M for muscarinic, M for muscarinic, N for nicotinic, right? So neuro, N for neuronal, so and neuromuscular and the neuronal. Okay, so obviously the neuromuscular, this receptor will be present in the neuromuscular junction. Very easy, this is present in the neuromuscular junction. And if you talk about the neuronal, what will be the locations over here? In the neuronal, again, location will be, you just need to remember the location over here. They can be presenting in the adrenal gland, they can be present in the ganglion, and they can be located in the CNS as well, right? So these are the common locations as far as neuronal receptor is concerned. Okay, so now let's just move further and let's just talk about a bit about these particular receptor. Okay, as far as neuromuscular junction is concerned, over here I'm just focusing on this particular system, neuromuscular junction, because one very particular disease we can discuss over here, myasthenia gravis, which is actually acting upon this neuromuscular junction. And what actually happens in the myasthenia gravis, actually we are having a formation of this is the autoimmune disease. So what will happen, the autoantibodies will be building up inside the human body, and they will be actually acting against the cholinergic receptors, and that's how they are making the muscles actually relaxed, and then it will be called as the floppy syndrome. This is also called as the floppy syndrome. For example, in the babies, we are calling them as floppy baby syndrome or floppy infant syndrome. So what is actually happening over here? Let me just show you one diagram as well. Okay, so here what we can discuss is, let me just so let me just clarify it further. In the myasthenia gravis, what we are seeing, basically the autoantibodies will be formed. As you can see over here, the autoantibodies, these autoantibodies I'm talking about, these autoantibodies we are talking about, these autoantibodies will be binding to the receptor. So what will happen, because these autoantibodies are binding to the receptors, they will block the surface of the receptors, so that acetylcholine, this is the acetylcholine, this will not be able to bind to the receptor. As the acetylcholine will not be able to bind to the receptor, the muscle will not be able to contract. so further muscle will not be able to contract, so no muscle activation. So that's why muscles will be relaxed, right? So that is happening in the myasthenia gravis, right? So that's how I'm just correlating this neuromuscular junction with that. So in the neuromuscular junction, the autoantibodies will be there, which is seen in the myasthenia gravis. Okay, I hope everything is clear, right? So in that's how we are seeing the muscle relaxation, right? That's how we are seeing the muscle relaxation. That was one link which you can relate to myasthenia gravis in detail. You will be actually studying that in the medicine section, right? Okay, now once we are clear with this, let's just move on to the basic locations of the receptors. We have talked about the muscarinic and the nicotinic, just a basic idea we took, that we are having a muscarinic receptor, we are having the nicotinic receptor as well. Now I'm just moving on to the locations as such, that what are the receptors we are having over there. Okay, and basically I'm just moving on to the muscarinic receptor because they are usually targeted in the FMGE examinations. So we are just moving on to the receptors as far as muscarinic system is concerned, because we are having a several receptor. We have talked about the neuroneuronal, right? Neuromuscular, neuroneuronal. We are done with the nicotinic one. I'm just focusing on the muscarinic now, and many questions have been targeted as far as locations are concerned over here. So just let's just talk about them. So as far as muscarinic receptor is concerned, we are having some subtypes over here, right? M1, M2, M3, M4, M5. Okay, that much big list we are having. M4, M5 we don't need to bother about. We don't need to bother much about them because they are not asked also. And just one location you can remember for them, that is the CNS, common location, M4, M5. Most of the questions they will be actually targeting from three subtypes of the muscarinic receptor. These are the M1, M2, and M3. So let's just talk about them. So first receptor over here which we are going to talk about, that is the M1 receptor, right? That is the M1 receptor over here. That will be the first one. In the M1, what we are seeing is the location is very important. Location is very important. So CNS is the first location which you need to remember over here, and the GIT is the second location which you need to remember, right? So CNS and the GIT. In the CNS, what we are seeing is, in the CNS basically they are actually increasing the cognition power. Okay, so it will be actually inducing the action potential, and basically it will be increasing the cognition in the patients, right, by stimulating the M1 receptor in the CNS, right? So there is one drug also named as taclifencin, which is the M1 agonist, which we are using for the Alzheimer disease. Why we are using that in the Alzheimer disease? Because in the Alzheimer disease there is a problem for the cognition, so we want to increase the cognition power of those patients. So that's why taclifencin can be used. So I'm just writing over here that there is one drug which is called as taclifencin. Okay, so that is basically the M1 receptor agonist, right? M1 receptor agonist, and that's how it is actually increasing the cognition power of the patient, and that's how we are using it in the Alzheimer disease, right? That's how we are using that in the Alzheimer disease, right? Everything is clear till now, right? In the GIT, if you talk about, it is actually increasing the secretion. It is actually increasing the secretion over there in the M1 receptor, right? So that is the case. If you talk about more further over here, we are moving on to the second common location of the muscarinic receptor, that is the M2 receptor. Now M2, just remember, it is present in the very beautiful organ of our human body, that is the heart, right? That is the heart. So I will just draw it in a more medical fashion. So like this is the heart, right? So over here we can just remember the heart location. So in the heart, what we are having in the heart, yes, everybody knows we are having a sinoatrial node, SA node, your pacemaker only. Or what else you are having? We are having the AV node, right? Then you might tell me that in the heart we are having the myocardium, which is helping us in contraction, and that's how it is helping us to maintain the cardiac output of our human body. Then you might say that there is nodes and the myocardium. Yeah, these are the basic structures we are having in the heart. So in the SA node, if you talk about everything over here, it will be decreasing, right? Basically, so I can clearly say that if you talk about the SA node over here, what is the function of the SA node? It is actually a pacemaker. It is increasing the heart rate, right? So over here it will be decreasing the heart rate. But the function of AV node, it is just helping us in conduction. So conduction means what? So over here conduction power will be decreasing in this case, right? So if you talk about the myocardium, contractility power will be decreasing, so contraction will be decreasing, right? So in other words, you can write over here that there will be the negative chronotropic effect it means that heart rate is decreasing. Negative inotropic effect, it means the contraction power is decreasing, right? Negative bathmotropic effect also, right? So that is the decreased conduction over here. So these kind of effects we can see very clearly over here. Okay, so overall the cholinergic system, if you will be stimulating the cholinergic system, it will be causing the bradycardia because it is slowing down the heart over here, right? With that, we're just moving on to the next receptor over here, M3. M4, M5, we don't need to bother. Just remember the common location, that is CNS. Nobody will be bothering you about M4, M5. As far as M3 is concerned, everywhere, guys. Just CNS can be the location as well. Just remember that M1 was in GIT, M2 was in heart, and M3 is everywhere. So everywhere, what do I mean by that? Let me give some example over here as well. For example, GIT, yes, it is present over there. In the GIT, everywhere, it is just increasing the secretions, right? So in the GIT, what will happen? It is increasing the secretions, it is increasing the contraction over there. So it is increasing over there. So GIT is one location. Several glands, okay, yes, that is the location for the M3 receptor. Several, the lungs in the bronchi, the bronchi in the lungs, that is a common location. Your urinary bladder, that could be the location, right? So in the iris, that could be the location, right? So these are the just common locations over there. And over there, what it will be doing? Increasing secretions, increasing contraction, all of those things. Increasing contraction, secretions over there. Okay, what else? In the glands, it is again increasing the secretion, right? In the bronchi, it is causing the constriction over there, so it will be causing the bronchoconstriction. I'm just writing BC over here. It is causing the bronchoconstriction. In the bladder, it is increasing the contraction again, so more urine will be happening, like that. Okay, in the iris, it is acting on the circular muscles and causing the meiosis. Very important aspect. The question has been asked many times, meiosis, right? So question has been asked many times, just writing over here. Okay, the question has been asked, right? So it is very, very important. Meiosis means pupilloconstriction. What is the meiosis, guys? Pupils are undergoing constriction. So I'm just writing pupilloconstriction. Pupilloconstriction, right? Okay, till now everything is done, everything is easy, right? So we are done with the receptors as well. M4, M5, just writing for the completion sake. M4 as well as M5, they will be presenting in the CNS, right? Just remember about that common location, they will be presenting in the CNS, right? So we are done with the receptors over here. Okay, now we're going to the major chunk over here. That would be the cholinergic system, guys, right? So that would be the cholinergic drugs, basically we are moving on, right? So let's just talk about this particular thing. Now we have just talked about the basic things over here. Now it will be easier for us to just talk about the drugs part over here as far as cholinergic system is concerned, right? So as far as this system is concerned, we are having two categories over here, as I said previously as well, that we are having a direct cholinergic drugs, direct cholinergics, and we are having the indirect cholinergics. Now what do I mean by that, guys? Indirect and indirect cholinergics, right? So let me just clarify myself, what do I mean by that. So direct cholinergics, here we'll be talking about that directly they will be acting on the receptors. I mean that if somebody is there who is actually stimulating these receptors directly, just drug came and just directly stimulating that is the direct. It is showing the direct effect, right? So a drug is going to the neural system and it is showing the direct effect, that is called as the direct cholinergic drug. And if the drug is there which will be inhibiting this particular seizure, right, that will be the indirect cholinergic drug. Okay, so I'm just writing indirect cholinergic drug. Now what will happen? They will block the seizures, so seizure will be paralyzed, seizure will not be working. If the seizure is not working, what will happen? They will not be able to cleave down this acetylcholine. If they will not be able to cleave down the acetylcholine population or acetylcholine number will be increasing in the synaptic gap. As the number will be increasing in the synaptic gap, what will happen? They will be having more chances to bind to these receptors. And that's how more activation of the cholinergic system will be able to happen. So in both the system, we can see acetylcholine will be able to bind to the receptor very easily. So one is directly stimulating the receptor so that acetylcholine can bind, more and more acetylcholine can bind to it, and another one is inhibiting the enzyme over there, so indirectly it is showing its effect. That's why they are called as the indirect cholinergic drugs, right? So I hope just you have a clear idea about the direct and the indirect cholinergics now. Now just moving on to the direct cholinergic first, and then we'll talk about the indirect one. Okay, so just jumping into the direct cholinergics now. In the direct cholinergics, we can talk about further two categories over here again, guys. So in the direct cholinergic, further we are having two categories. One is the nicotinic agonist and one is the muscarinic agonist. Obviously, these two categories can be expected over here. So one is the muscarinic agonist, muscarinic receptor agonist, or you can say muscarinic stimulators, and another one is the nicotinic stimulators or nicotinic agonist, right? Very easy. Muscarinic and the nicotinic agonist. In the nicotinic agonist, these days we are not just we're not practicing them as such. For example, nicotine, right? We want to reduce the burden of nicotine from our population, like cigarettes and smoking stuffs are containing the nicotine stuffs. One more is there, varenicline or varenicline, right? Okay, these are used in this can be used in the smoking dependence basically. If you talk about the nicotine also, there are availability of the nicotine patches which we can use as a transdermal patches to avoid the smoking dependence. Now if you talk about the muscarinic agonist, now that is the main area where they are focusing the MCQs over here. So in the muscarinic agonist, we are having two categories basically. One is the amide category and one is the cholinesterol category. Okay, so I'm just discussing this section in the next slide over here. So yeah, so here we are having the amides, and in this section we are having a cholinesters, right? So let me just brief the info what we can just understand from this particular terms. So in the amide section, we are having some drugs over here. What kind of drugs we are talking about? First of all, let me just clarify over here. In the amide section, okay, these drugs, they will be lipid soluble, and the concept is like if some drug or if some substance will be the lipid soluble, then it will be easier for that substance to go through the membranes, to go through the cell membranes, because our cell membranes are made up of lipids, right? So they don't need any kind of carrier or any kind of transport protein. They will be just going through the cell membrane very easily as they are lipid soluble. Okay, so lipid soluble means they will be actually going through the cell membrane very easily. It means that they can cross the blood-brain barrier, as our blood-brain barrier is also made up of lipids, right? So this is very easy. Now what can be the drugs which we can discuss over here? That is the main area. So drugs which you can remember, which is very popular as well at the same time, that is the pilocarpine, right? That was the pilocarpine. So pilocarpine is the drug. At the same time, you must have heard about the physostigmine, for example, right? So if you talk about the pilocarpine over here, right? If you talk about the pilocarpine over here, pilocarpine basically it is used for the glaucoma, right? Actually, it is the drug of choice. It is the drug of choice in the angle closure glaucoma. We are having two types of glaucoma, wide angle glaucoma or open angle glaucoma, and the narrow angle glaucoma or the angle closure glaucoma, right? So it is the drug of choice in the angle closure glaucoma. Okay, and this is the MCQ, right? Now next point is it is also causing the dry mouth, right? It is also causing the not the dry mouth, basically it is causing the, as I said, that it is increasing the secretions, right? It is increasing the secretions everywhere. So in the salivary gland, if you talk about which receptor I am expecting over there, I am expecting the M3 receptor, right? So it will be increasing the secretions. So if I will be using this drug, it will be increasing the secretions. So it can be used for the dry mouth also. It can be used for the dry mouth, and dry mouth is also called as the xerostomia. Dry mouth is also called as a xerostomia, right? So it can be used over there. But if somebody will be asking you that what is the drug of choice in the xerostomia, so that is the cevimeline, right? So cevimeline is the drug of choice. Okay, it is the drug of choice in dry mouth, or also called as the xerostomia, right? Other drugs over there are present as well. For example, physostigmine is there, ecothiopate is there. I'm just mentioning about the physostigmine, that is more relevant for you. So physostigmine is the drug which is coming in the amides category as well. Okay, So once we've discussed about this much drugs over here, okay, so we have discussed about the pilocarpine, which you need to remember, cevimeline you need to remember, and the physiostigmine you need to remember. They are coming in the category of the amides. If you talk about the cholinesterase category, they are just opposite. So like amides were lipid soluble, they will be lipid insoluble. Okay, meanwhile I'm writing, just tell me, they will be crossing the blood-brain barrier or not? Yeah, so they will not be crossing the blood-brain barrier, so they can't cross blood-brain barrier, right? And so that's why if you are giving this particular drug, okay, will you be seeing any kind of side effect related to the neuronal system, related to the nervous system? No, you won't be seeing any kind of side effect related to that, because it is not crossing the blood-brain barrier. So you're giving some drug to the patient, and this drug will not be crossing the blood-brain barrier. Okay, so it will not be showing the central side effects, or it will not be showing the nervous system side effects, basically, if you are using the cholinesterol drug. So that is kind of a benefit of using this cholinesterol drug. Okay, so over here, basically it is not crossing the blood-brain barrier, it cannot cross the membranes over there. What are the drugs basically which we can talk about in this particular cholinesterase category? So drugs over here which we can discuss is, the first one is the very popular one, that is the acetylcholine, right? Acetylcholine, right? Second drug which you can use over here, for example, that would be the bethanicol, which you can use in this category. Then you might have heard about the carbachol, right? That can be used. Methacholine can be used over there, right? Methacholine can be used over there, right? What you can remember basically from these kind of drugs is, like, if you talk about the bethanicol, right? What you can remember about the bethanicol, basically, bethanicol is basically acting on which receptor, guys? M1 and M3 receptor. Just remember that. Basically it is acting on which receptor? M1 and M3 receptor, right? And it is kind of a having a selectivity, right? Good selectivity actually. It is not binding to the nicotinic receptor much. It is not binding to that much. If you talk about the carbachol, right, it is also basically binding on M1 receptor or the M3 receptor. Okay, but at the same time it can bind to the other receptor also, like it can bind to the nicotinic receptor also. So you will be experiencing the side effect at the same time. Nicotinic side effect you will be experiencing in this case. If you talk about the methacholine, this is basically binding to the M2 receptor. Okay, and once they have asked you this, that methacholine, it is binding to which receptor, basically it is stimulating which receptor, basically. So methacholine is M for methacholine, M for M2. Okay, so basically it is stimulating the M2 receptor, right? Now next thing over here which we can basically discuss, that is about this was about the direct cholinergic, right? All of these things are like physiostigmine, pilocarpine, acetylcholine, bethanicol, carbachol, methacholine. Okay, these are the drugs which we are talking about them in the direct cholinergics. Okay, basically, right? Not the physiostigmine. Physiostigmine is coming in the indirect category as well, but most of the drugs other than that is coming in the direct cholinergics, right? If you talk about now another drugs which we are going to talk about right now, that is the indirect category, or I mean to say that indirect cholinergics will be moving on further. Okay, so we have talked about the direct cholinergics. Now we will be moving on to the indirect cholinergic category. Okay, so in the indirect cholinergic category, basically we will be talking about the OP poisoning over here, or the organophosphate. Okay, we have just summarized about that indirect agonist as well. I'm just writing over here indirect agonist, right? Indirect cholinergics, I'm writing rather, indirect cholinergic agonist or indirect cholinergics, right? So let me just brief the indirect cholinergics over here. So concept is very simple, that they will be blocking those scissors which were acetylcholinesterase enzyme, and that's how they will not be able to cleave down the acetylcholine, and that's how it will be increasing the population of acetylcholine in the synaptic gap, and they will be able to more acetylcholine will be able to bind to the receptor and will be able to show the effect. So which kind of drugs we can talk about over here? So over here we can talk about, first of all, that is the organophosphate, guys. Straight away writing over here, so that is the organophosphate. Okay, organophosphate, and very commonly we are just abbreviating that as OP, organophosphate, or you might have heard about the organophosphate poisoning, OP poisoning, right? Organophosphates are kind of irreversible blockers of those acetylcholinesterase enzyme, or those seizures, right? they will be blocking them. But for initial 30 minutes, they are the reversible blockers of the seizures, and after the 30 minutes we can't do much, right? After the 30 minutes they will be becoming as irreversible blockers. So what we know is that they are the overall irreversible blockers of which enzyme? Those seizures, acetylcholinesterase enzyme. Okay, those seizures, right? You will be remembering this with this sign. Okay, so eventually what will happen? Okay, more and more acetylcholine will be there, right? We can understand that very easily. Now let me just talk about these things. So organophosphates, I said that for the initial 30 minutes, right? For the initial 30 minutes, I'm just writing it over here as well. So for initial 30 minutes we can do something. For initial 30 minutes they are acting as OP, right? Organophosphates are reversible blockers of acetylcholinesterase, but after 30 minutes usually they become irreversible. So we have just time that initial 30 minutes period, but obviously if the patient will not be able to come to the hospital in time, right, which usually happens, okay, 30 minutes is very less short duration, so at that point of time, you can't do much in these cases, right? Or you are taking some time to make diagnosis over there. Again, these kind of things will be making the delay over there. So this is the thing over there, as if you talk about the organophosphate. So basically organophosphate poisoning is the major issue over here. If some patient is there which is coming up with the organophosphate poisoning, right? Now these can be present in the pesticides and all. They can be easily, you can see them in the form of pesticides and all. So pesticides and the insecticides, these are the common sources. Pesticides and the insecticides, these are the common sources for organophosphate. And mostly the farmers and all, they are actually working in the crop fields, so they are just spraying these insecticides on their crops. So even if this insecticide will be actually, even the drops of the insecticide are coming on the skin surface and all of those things, actually they are just covering their mouth and hand as much as they can cover. They are actually doing that, but still if the drops and all, they will be coming up onto the skin surface and all. From the skin surface also, it can just reabsorb into the blood circulation and can cause the OP poisoning. So that is the thing, that's why they are very, very harmful. So the patient will be coming up with the cholinergic symptoms. Now what are the cholinergic symptoms? I told you, right? They will be stimulating the muscarinic receptors. They will be stimulating the nicotinic receptors. So that flesh will be seen in the patient. Like if it will be stimulating the M1 receptor, CNS symptoms will be there, GIT symptoms will be there. M3 receptors, the patient will be having increasing secretions, bronchoconstriction, and all of those things, right? I just told you over there that all of these things will be seen in the patient, right? All of these things will be seen in the patient, right? M1, and if you talk about the heart, bradycardia will be there in the patient and all, right? These things will be seen in the patient. So OP poisoning, in this case, that will be seen, right? How about the pupils, guys? How about the pupils? I told you in the iris we have having the pupils, M3 receptor, what will be causing? Meiosis. So you'll be seeing the meiosis in the patient if you are seeing the, okay, so that's why these receptors and their location is very, 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 very important. Okay, so let's just talk about that. Pesticides and insecticides, they might be the sources of this thing, right? So if the patient is coming up with the OP poisoning, this can also be called as cholinergic poisoning, right? So I'm just writing over here, OP poisoning can also be called as the cholinergic poisoning. And what will be the symptoms? I just told you those symptoms will be there, right? M1, M2, M3 receptors, okay, these symptoms will be there in the patient. Okay, so what you'll be doing in these cases? Drug of choice for these cases, for this poisoning, will be the atropine sulfate, guys. Will be the atropine sulfate. Okay, atropine sulfate, we'll talk about that in detail in the next section. But atropine sulfate is the anticholinergic. So atropine sulfate will be given. That's how it is acting as an antidote, right? So atropine sulfate will be given for these patients, and we'll be waiting for we'll be waiting for 2 to 4 mg will be given, and we'll be waiting for 10 minutes, and again the next dose will be repeated over here in this case. So atropine will take care about the muscarinic symptoms in this patient, like M1, M2, M3. It will just reverse that effect. But what about the nicotinic symptoms? it will be stimulating the nicotinic receptors also, organophosphate. So for that purpose, we are actually giving one more drug, and these are the oximes. These are the oximes. Which oxime? For example, pralidoxin. Which oxime is used very commonly for this kind of poisoning? Pralidoxin is very commonly used. That was the MCQ once, right? Okay, so atropine sulfate followed by the oximes. Why you're giving atropine sulfate? I am giving the atropine sulfate for muscarinic symptoms. I will be handling the muscarinic symptoms. They will be, blocking the muscarinic receptors so that, OP poisoning will not be able to happen, right? And oximes, they will be, why we are giving them? For the blocking the nicotinic receptors, right? So I hope you are able to, get the idea why we are using that. So atropine sulfate followed by the oxime. This is the pralidoxin. Or you can also use the obidoxime, or you can use the diacetyl monoxamine, right? DAM. What is DAM? DAM is diacetyl monoxamine. Okay. So DAM is diacetyl monoxamine. Okay. So till now we have talked about this much. Okay. So they are used for the nicotinic symptoms. If once they have asked you one question, okay, for the OP poisoning, organophosphate poisoning, or the cholinergic poisoning, what is the question? What is the drug of choice? So answer would be very easy. Atropine sulfate has been asked number of times. Then once they asked you if the patient is coming up with the carbamate poisoning, in the carbamate poisoning, which cannot be the correct statement, and one of the statement was pralidoxin can be commonly used for the carbamate poisoning. No, carbamates, for the carbamate poisoning you can't use the pralidoxin, right? For the carbamate poisoning we are not using the pralidoxin, and that was a wrong statement in that case, right? Pralidoxin will be used for the OP poisoning, not for the carbamate poisoning. That was asked once, so that's why I think in the PG examination, one of the PG examination, they had asked you this. So yeah, this was a question once, so that's why I just mentioned over here. Okay, so in the carbamate poisoning, basically what is happening is that in the acetylcholine esterase enzyme also, they are the sites. Okay, and OP poisoning is just binding to one site, but in the carbamate poisoning it is binding to both the sides of the acetylcholine, right? And I mean that if if this is the acetylcholine esterase, let's say I'm saying that if this is the acetylcholine esterase enzyme, these are the two sides of the acetylcholine esterase enzyme, right? So if you talk about the OP poisoning, it is just binding to one side. But if you talk about the carbamate poisoning, okay, carbamate poisoning, it is binding to both the sides, here also, right? That's why it is very, very difficult now. So carbamate poisoning, you have no idea, like you don't have any drug over there to just cause the irreversible changes over there. So pralidoxin will not be able to use at that point of time, because pralidoxin can only be used when one site is free. Okay, either the anionic site, either the cationic site. Let's say this is the cationic site and this is the anionic site. That much detail is not needed. But if one site should be free for pralidoxin to work, but in the carbamate poisoning both the sites will be filled up, so both the sites will be occupied by the carbamate, so it will not be able to work over there. So once this question has been asked, so that's why I just discussed over here. Understood? So we have just discussed about the OP poisoning as well, organophosphate poisoning as well. Now we are just moving on to the another section over here in the indirect cholinergics, and that is about tertiary amines and the quaternary amines. I need to talk about that as well, as it is also important. So here also in the direct cholinergics also I just talked about the amides and the cholinesters. Here I am just differentiating tertiary amines with the quaternary amines, right? And let's just talk about these kind of drugs as well, like what kind of drugs we can discuss over there in these two categories, right? Again guys, same things. In the tertiary amines, this is the lipid soluble, right? Here you will be talking about the lipid solubility. It means they can cross the blood-brain barrier, there is no doubt in that, can cross blood-brain barrier. On the other side, I'm just repeating, this will be the lipid insoluble, so cannot pass through the membranes, cell membranes, so cannot cross the blood-brain barrier, obviously, right? No doubt about that. Now just moving on to the drugs basically, okay, which is relevant to us. Now if you talk about the drugs over here, I'm just mentioning about some of the drugs, right? For example, one is physostigmine. Yes, you heard it right, that is a physostigmine, right? Physostigmine, if you talk about, okay, physostigmine, if you talk about, somebody will be asking you about the physostigmine, as it is very commonly used. It can be used in the close angle glaucoma, can be used, right? Listen to me very carefully, can be. used in the closed angle. I didn't say drug of choice. Drug of choice was pilocarpine, but physiostigmine can be used in angle closure glaucoma. I'm just writing ACG. Okay. Now, drug of choice in what? Atropine poisoning. Are you understanding? Drug of choice in atropine poisoning or the atropine toxicity. Atropine was the drug of choice in organophosphate poisoning or the cholinergic poisoning. Physiostigmine is the drug of choice in atropine poisoning. MCQ, very important MCQ, has been asked n number of times. Okay. Now, moving further, if you talk about another drugs, for example, rivastigmine. Okay, one more drug is there, that is like rivastigmine is there, right? Rivastigmine is there, which is coming in the category of tertiary amines only. Galantamine is there, tacrine is there, right? Galantamine is there, tacrine, right? Donepezil. Let me just tell you over here, these drugs which I am talking about over here, right? Like these particular drugs which I am talking about over here, they are also used in the Alzheimer disease, right? Alzheimer disease. Okay, so these are the drugs which can be used in the Alzheimer disease as well, right? Okay, on the other hand, if you talk about what are the drugs which we can talk about in this section, right? So here we are using very important drug, and I'm sure that you must have heard about this drug. That is your drugs which can be used in the myasthenia gravis. Yes guys, you heard it right, which I had talked about that in in the previous slides also. Myasthenia gravis, right? About the pathophysiology of the myasthenia gravis. Autoantibodies were formed and they were blocking the receptors, right? Cholinergic receptors. So over here, first drug which I'm gonna talk about, that is the adrophonium, guys. Adrophonium. What about the adrophonium? Adrophonium, right? Very important. Adrophonium can be used for the drug of choice. Adrophonium can be used as a drug of choice for making the diagnosis of myasthenia gravis. I'm just writing the MG, right? Next, it can also be used for differential diagnosis, for differentiating the myasthenia gravis with the cholinergic crisis. Okay, so it can be used for differentiating the cholinergic crisis with the myasthenia gravis. From cholinergic crisis. Okay, actually what happens is, if the patient is coming up with the cholinergic crisis, right, the patient, if you will be giving the adrophonium to this patient, adrophonium is having very short half-life. Okay, so you will be giving this drug to the patient, and after few minutes only, the effect of the adrophonium will be vanishing away. So that's why we are just checking for for confirming our diagnosis of myasthenia gravis. If the patient will be having myasthenia gravis, the patient symptoms will improve. That muscle weakness will be improved, because if you will be giving adrophonium, right, it will be increasing the content of acetylcholine in the synaptic gap, and they will be that excess amount of acetylcholine in the synaptic gap will be removing the autoantibodies from there, and they will be binding to that, so that muscle contraction will be resuming in the patient. But if the patient will be having cholinergic crisis, okay, it will worsen the symptoms of the patient. So that's how it can be used for differentiating myasthenia gravis from the cholinergic crisis. That is about the adrophonium. If you talk about the next drug over here, that is the neostigmine, right? That is the neostigmine, right? As far as neostigmine is concerned, over here we are talking about the again myasthenia gravis. Neostigmine can be used for treatment, right? Can be used for treatment of myasthenia gravis. Okay, it can be used for reversal of non-depolarizing muscle relaxant. It can be used for cobra bite, right? It can be used for bladder atony, and paralytic ileus. It can be further used in curare poisoning, right? It can be further used in curare poisoning. All of these are MCQs actually. That's why I'm just writing here and there. They have asked the MCQs on these uses of the neostigmine. They are just fond of neostigmine. They are targeting the neostigmine every year, and they are just asking on the uses of the neostigmine. Right? Once they have asked you that what can be a drug used for the cobra bite, so answer would be the neostigmine. Can be used for the curare poisoning, that is the neostigmine. Bladder atony or the paralytic ileus, neostigmine. Right? So they have just MCQs, so I have just mentioned about them. Right? Next, after the neostigmine, we can talk about the pyridostigmine. Now, if you will be asking that what is the drug of choice in the myasthenia gravis, for making the diagnosis, we are saying that drug of choice is atrophinia. For treating the myasthenia gravis, we are saying it is neostigmine. But pyridostigmine, we are saying that it is the drug of choice. It is the drug of choice in myasthenia gravis. Now, why is it so? Why not neostigmine? Because neostigmine is having a half-life of about 5 to 6 hours, but pyridostigmine is much longer than that. If you're using the pyridostigmine, okay, we can use that even once a day, and patient will be feeling fine for the myasthenia gravis. If you talk about the neostigmine, still you have to give it BD or TDS. I mean twice a day or thrice a day. But pyridostigmine, the patient will be more comfortable with that, because just one tablet can work for that. So that's why drug of choice in the myasthenia gravis would be the pyridostigmine. Okay, so I think everything is clear till now. That is about the basic idea about the cholinergic system. In the next session, we'll be talking about the anticholinergics, right? But before leaving, let's just try to apply our knowledge into these MCQs as well, so that we are having a better insight. Okay, so if you talk about the first MCQ over here, that is about the botulinum toxin they are asking you, right? So for example, botulinum toxin acts by, so botulinum toxin is acting by the, over here, which you can see over here, presynaptic inhibition, right? Presynaptic inhibition of release of acetylcholine. If you talk about what I told you, that here was the presynaptic neuron and it was the postsynaptic neuron. Here was the presynaptic vesicle over there, and what was happening? It was just blocking the exocytosis of the calcium ions, right? So here it was blocking this thing. So it was the botulinum toxin over here, right? So answer would be the presynaptic inhibition of the release of acetylcholine, right? Next question over here would be botulinum toxin, which is decreasing the transmission across nerve terminals. Okay, it is an example of what? It is an example of, yes, that is a presynaptic blockage. We have just talked about that. It is an example of presynaptic blockage, right? Next question is, a farmer present in the OPD clinic with sweating is there, lacrimation is there, pinpoint pupils are there. What could be the possible diagnosis in such case, right? So we have just talked about, these are the cholinergic symptoms they are talking about. In the MCQ, you have to understand that what kind of symptoms they are talking about in the question. So these are the cholinergic symptoms. For example, you can see pinpoint pupils, right? It means you are stimulating the M3 receptor over here, right? You are talking about the sweating, you are talking about the lacrimation, again they are talking about the M3 receptor over here. So these are the cholinergic symptoms, or I can say this is the cholinergic poisoning, which can also be called as the organophosphate poisoning or the OP poisoning over here, right? So that is the answer. It is also called as a cholinergic poisoning. And just tell me the antidote for this particular patient. Yeah, antidote will be the, yes, I can hear that, right? That is the atropine in this case, right? Atropine sulfate would be the drug of choice as far as antidote is concerned in this case, right? So next question, let's talk about that as well. So botulinum toxin acts on what? Botulinum toxin is actually acting on the presynaptic neuron. So yeah, over here answer would be the inhibition of the release of neurotransmitter, or the presynaptic release inhibition will be there. Presynaptic release inhibition of acetylcholine. So that should be the proper answer. Question number 37, if we talk about action of M2 receptor is asked over here. So M2 receptor, I told you M1, M2, M3, right? So M2, I told you about the heart over there. In the heart, we have talked about the bradycardia and all of those stuff will be happening, SA node, AV node, and it will be causing the blocks and all, and the myocardium inhibition. So it will be causing the bradycardia. I'm talking about the parasympathetic system over there, right? So it will be basically acting on the vagus nerve over there. So basically we are talking about the parasympathetic nerve or the parasympathetic ganglion involvement over there, right? Moving on further, neostigmine, right? Neostigmine used in all except. So neostigmine can be used, just told you about the uses. That's why I was focusing on the uses over there. It was used in the curare poisoning. Yes, it was used. It was used in the Myasthenia gravis, yes, it was used. Was it used in the snake bite? Yes, I told you it was a use. Just revise the notes over there. So what is the answer over here? OP poisoning. Yes, OP poisoning. It is not used for the OP poisoning. For OP poisoning, what we were using? Atropine was used. Right? Atropine was used. I hope you are with me. Question number 71. Action of M2 receptor is seen at. Action of M2 receptor. M2 was presenting in the heart, focusing on vagus nerve again. Vagus nerve. What should be the answer over here again? Yes, I can hear that, right? That's the parasympathetic ganglion, parasympathetic nerve over there, right? So the answer will be the parasympathetic nerve, right? We'll just ask you action of M2 receptor. Okay. Question number 72 over here. Question number 72, methacholine acts mainly as. Methacholine, if you remember guys, I told you bethanycol and carbachol were acting on the M1 and M3, right, as a preference, and methacholine was acting on the M2 receptor. So it was stimulating the M2 receptor. It was stimulating the M2 receptor. So here the answer would be the M2 agonist, right? It will be a M2 agonist, right? So I just hope I was able to depict the brief knowledge about the cholinergic agonist, and I hope you will be able to solve as much MCQs as you can as far as this particular system is concerned. In the next session, I will be trying to discuss about the cholinergic antagonist. Please let me know your views about this particular session in the comment section below, and let me know about the doubts as well, right? So thank you so much for joining this session, and I will be seeing you in the next one. Until next time, bye bye, take care.